I'd like to introduce Bobby Hardman. Bobby is a clinical nurse leader, or will be very soon. She's how do you say her title?
Patient care facilitator.
Patient care facilitator at Azle Hospital. And Bobby has a poster with us today, and the name of the poster is Primary Care Following Hospital Discharge. And what I would like to hear from you, first of all, is why you thought this was a good idea to do, because I know that your population's very specific. You're only looking at primary care following discharge among older adults.
That's correct.
So tell us a little bit about why you chose that age group and why the follow-up with primary care is important.
Okay. The largest percentage of our patients out at Azle are in the elderly, the 60 and above population. And so we've found that they were having some difficulty in following up with the primary care physician. Either they didn't have one or they, didn't have transportation. There was always something that was creating a barrier for them continuing care outside of the hospital. So we thought we would formalize a study to kind of validate that and kind of see exactly what the barriers were.
Okay. And what is different about Azle than other hospitals? When you did your lit review, for instance, I'm sure you read about transitions in care from hospital to wherever, and all the things that were important there. Did you encounter other hospitals like Azle?
We did. We focused in, it's a rural area. It's considerably outside of the city limits. We border on the county lines of 3 different counties, and so that's when we did the literature review. We focused in on the rural communities, and we found that, it's a different population, it's a different socioeconomical, and they face different barriers.
Okay. Well, tell us about how you organized the study. What were the procedures? What kind of design was this?
We designed a tool. It was a survey tool that had questions both qualitative and quantitative, and it was designed and approved by the IRB, and then we set out how to protocol specifically for the elderly population, 60 and above, that were hospitalized on the inpatient. And what we did is we got approval, the authorization for them to participate, and then we sat down with them. It usually took about half an hour, and we would go through the questions, and it was a scale as how they rated, their ability to, their perception of following up, and then very specific questions that we got verbal responses from them.
Okay. Now, in this particular study, you got informed consent in a written form.
Correct.
Right?
Correct.
Why don't you tell us a little bit about how that went, especially with your population, which are elders? Did you find that easy or hard? What things made it easier?
I think we had a handful of patients that were skeptical. They didn't know what we were going to do with the information, even though we told them it was completely anonymous, that their name wouldn't be on there. They were worried about their privacy being violated. And it didn't matter if we put in there or not that how it was going to be protected. They were skeptical of doing that. But a lot of them did partake in doing it, and I think it really helped with my role in approaching it, because I've had a few days usually to develop a relationship with them, and then as they started feeling better, I would say, hey, you've been here, we think we're going to discharge in a day or two, would you like to take this survey and help me identify if there's any barriers to following up with primary care physician. Okay. So I think it helped, just that I had that relationship with the patients, but some of them were still skeptical. I was going to sell their information.
Right. And of course then they didn't have to enroll.
Correct.
Right?
Correct.
Okay. The other thing I wanted to ask you about, because of the age of your population, was how difficult you found it to actually gather data. Did they have problems with the survey? How much did you have to intervene to help them with just the doing of the survey?
We found there was quite a few that would have dementia, which would exclude them, but sometimes it wouldn't be a part of their history, but as we're going through it, we found some kind of undiagnosed things that was kind of barriers to them being able to understand it. Health literacy became kind of an issue. Some of them couldn't read it. They wanted us to read it. Sometimes it was a vision. Sometimes they couldn't see to read it. If I read it to them, then they would answer the questions. Sometimes it just took a little bit more prodding, kind of explaining they didn't quite understand what the question was asking. And I saw that, as you got higher in the age bracket, closer to 60 was usually pretty good, but as you got, older in the upper 80s, and I think the oldest we had was a 92-year-old.
Right, I noticed you had quite a range. And I helped you with a few of those, and one of the things I noticed was that some of your patients really wanted to talk.
Yes.
And use the research opportunity as really an opportunity for socializing. That
Yes.
seemed to mean a lot to them.
Because, some of them, if you just read through it and got the responses and wrote it down, the whole process should have taken about 15 or 20 minutes. And some of them took upwards of like 45 minutes to an hour because they really did want to socialize.
Okay, well, tell us then what you did with the data once you had it. You had two kinds of data. They rated some of the items on the survey, so there was scaled data. And then they had open-ended questions. So they had qualitative data. What did you do with this?
So what we did is we created an Excel spreadsheet and we put the qualitative data in there, and so we were quantitative data that we put on the actual spreadsheet, and then we were kind of calculated those number of responses. On the qualitative side, what we did is we cut each response out and we just kind of laid each section out question by question and kind of developed themes that way. Once we had them, then we put them into envelopes, and then we had our themes, then we kind of sat down and formalized them more into 3 major themes, and then there ended up being about 11 sub-themes to it.
Right. And what we actually did was a content analysis, so there's different kinds of qualitative work, and that's what we ended up actually doing.
Yes.
And what you're describing to us is the conceptual coding. So we went through that and tried to pull out all the concepts they were describing and then put them into classes.
Correct.
Is that how you remember
Yes.
it? Yeah. And then the quantitative data actually was rather interesting because we found some, what we thought were biases, right? Tell us a little bit about what the results were on the quantitative part of the tool.
We found that pretty much it was, they had a really hard time going anywhere in between. It might have been on a scale of 1 to 7, and it was either all or it was none. It was either a 1 or it was a 7. There was very, very few that were in the middle.